Very good evening to all. Myself, Atanu Banerjee. I'm from Abbott Vascular. I welcome all of you in this Eastern Cardiology Conclave Chapter 2 webinar. And we are very happy that we have Dr. Subha Banerjee sir with us as a moderator for this session. And I would request Dr. Banerjee sir to start the session. Over to you, Dr. Banerjee sir.
Thank you, Atanu. Atanu, it's my pleasure to be here and being joined by a panel of luminaries. We have with us Dr. Shunib Banerjee as an expert panelist. He's the director of Kolkata Heart Lung Center, Kolkata, and senior interventional cardiologist. We also have with us Dr. Mustafa Zaman. Dr. Mustafa Zaman is the professor at BSMMU Hospital and the president of Bangladesh Cardiovascular Research Foundation. With these eminent expert panelists, let's start with we have three speakers today. And the first speaker is going to be Dr. Adil Bashir Wozil, who is also a senior consultant interventional cardiologist at Kolkata Heart Lung Center. And he would be presenting a case on complex, a complex case with some interesting discussion. So over to you, Dr. Wozil. You may share your screen now.
Good evening, everyone. Am I able to share my screen?
Yeah, you can. Yeah, it is. Put it into the PowerPoint.
Yeah, good evening.
Screen.
So,
yeah.
I'm going to present a case on complex coronary intervention. The title will be Different Lesions, Different Strategies. So, we had a gentleman, 78-year-old gentleman with history of hypertension and COPD. He had an old history of inferior MI in 2003, for which he had received a bare metal stent in 2003, had been doing all along well. Then he presented with angina on effort class 3. Despite multiple anti-anginals and medical management, the angina persisted. ECG showed some T-wave inversions in chest leads. Echo was showing mild RWMA in old inferior wall territory and some mild RWMA in apex with a relatively preserved ejection fraction. So we went ahead and did a coronary angiogram. So the coronary angiogram revealed that there was a bifurcation lesion in LCX-OM, at very tight 90% bifurcation lesion. And in addition to that, the LED was heavily calcified, especially mid portion of LED. As you can see in the angiogram, there was a tram track type calcium with a very tight lesion in mid to distal LED. The RCA was okay. The old bare metal stent which was implanted around 22 years back. It was relatively fine with some mild late lumen loss. So we decided to go ahead with, after discussing with the family about all the amenities, all the treatment options, we decided to do the angioplasty of LAD and LCX. Both the lesions were complex, LCX having a bifurcation lesion and LAD having a tight, long, diffuse, heavily calcified disease. So initially we thought of doing the LCX lesion. So we initially went ahead with a provisional bifurcation stenting for LCX-OM lesion. We dilated the LCX-OM part of the lesion. Sequentially after that, dilated the LCX with 2.512 NC balloon. So after that, we went ahead. It was relatively the lesion opened on NC balloon dilatation, and we give a stent from LCX to OM, a 2.7521 drug-eluting stent. After that, did a post-dilatation with 2.75 12 millimeter NC balloon and a port with 3.6 NC balloon. After that, we did a recross into the LCX because the OM blow was a very big artery, especially the territory supplied by it was significantly large. So we opened the stent struts and did a recross. After recross, did a kissing balloon inflation, and this was the result after kissing. Initially, we had thought of a provisional bifurcation, and we thought we will leave it like that. But after some time, we found that the lesion was recoiling and there was some mild slow flow in distal LCX. So we went ahead and put another stent into the LCX with a TAP technique 2.5 12 millimeter drug-eluting stent. We did in LCX, dilated the stent, the balloon across the ostium in LCX to OM. After that, dilated the OM balloon, did a kissing after tap, and followed by a port with a 3.6 millimeter NC balloon. And this was the final result in LCX OM bifurcation. So after that, we did an IVAS run. Initially, we had attempted before balloon dilatation, we were not able to cross with the IVAS catheter. So we did an IVAS run after stenting. The result was relatively good and we were happy with the result. So after tackling the LCX OM bifurcation, we then went to the LAD in the same sitting, and in view of the diffuse, long, calcified, significant disease, we had already planned of doing an upfront rota ablation. We went ahead with the 1.5 millimeter bar. The entry into LAD per se, the entry and advancement were difficult since we had not planned to do any intervention in the osteoproximal LAD. So we just entered the LAD in a dynaglide mode, and after that did rota ablation of the mid to distal LAD. We had to do multiple runs, but the rota bar was not advancing. The main tight lesion in the mid LAD, it got crossed, but after that there was a bend beyond that. The bar was not crossing beyond that bend. After multiple, we had to do around 6 to 7 runs, but the bar still could not cross that bend. The tightest lesion was crossed, but the bend beyond that lesion were not able to cross. And at this point, patient complained of some chest pain, and we could see there was ST elevation on the screen. So we removed the bar and gave some dye, and we found that there was LAD was occluded. So what to do next? We after that we had to open the LAD very quickly because patient was the chest pain was increasing. We gave some nitrates, but and vasodilators, but it didn't open. Possibly there was a dissection which has caused the acute vascular occlusion. So we put in a microcatheter very quickly, exchanged the wires, and took a 2 into 12 millimeter SC balloon, which we were expected that it should cross now into the distal LAD, and did the balloon dilatation of distal LAD. So we did balloon dilatation of LAD, and the flow of LAD was restored. And there was some dissection at that point where the bar was not advancing. There was a dissection possibly that had caused the acute vascular closure. Once the distal LAD opened, we could pass a IVAS catheter, which we were not able to pass previously. So we passed an IVAS catheter to the distal LAD and did an IVAS run. So in IVAS, you could see the lesion was very, very tight. There was at places circumferential calcium, at places there was around 180 degree to 270 degrees arc of calcium. Calcium was not very thick in mid to distal LAD, but there was significant amount of calcium. So after we found that there is a significant amount of calcium. So we did a cutting, we used a cutting balloon, Wolverine 2.5 into 10 millimeters cutting balloon. We did the mid to distal LED, we did a cutting balloon inflation, and this was the result after dilating the LED with the cutting balloon. After that, we again took a IVUS run to look for the, especially the areas where we had circumferential calcium and a large arc around more than 180-degree arc of calcium to look for whether the calcium was broken. And I can see in the IVUS run, there was some luminal gain, and in addition to that, especially the circumferential calcium and these arc at 180 degree, 270 degree arc calciums, there were cracks in the calcium. So now we expected opening of the LED nicely. So after that, we did an 2.5 millimeter NC balloon inflation at higher pressures, and followed by, as we had previously planned, to do a drug-eluting balloon, give a drug-eluting balloon in the distal LED. So we gave a 2.5 millimeter into 30 drug-eluting balloon in distal LED. After giving the drug-eluting balloon, there was some dilemma. There was a discussion in the lab about this mid-LED dissection, whether to give a drug-eluting balloon or implant a stent. So after considerable discussion, we gave some dye in different views in epicranial, aleocranial to look for the extent of dissection, and the dissection was clearly visible on IVUS also, with some amount of intramural hematoma. And so after considering that the dissection was significant and it had already limited the flow of LED once, the LED flow got occluded at this point during the rotablation time. So in view of that, it occluded the LED once. We decided to go ahead with implanting a drug-eluting stent. So we implanted a 2.75 into 15 millimeter drug-eluting stent in mid-LED because of the spiral nature there and the vessel occlusion at this point. So after implanting a drug-eluting stent and dilating, this was the final result. After, there were some mild dissections in the distal LED, which we didn't consider because none of them was a flow limiting dissection, and the distal flow runoff was very good. There was TB3 flow. We couldn't do a final IVUS run as the patient was getting impatient and was not very much cooperative at this point of time. So this was the final result in LED. So some comments: the patient did well during the post-operative period and was discharged after 2 days. So seeing this case, we need different strategies for different disease morphologies. We might find in a same patient, different type of disease morphologies, different type of diseases in different vessels. And obviously, one strategy won't fill all of them. So we need to do different strategies, take different strategies in different morphology of the disease. And proper calcium management is very important, and it may many a times require more than one amenity. We have different available tools, so we may require more than one of the available tools to do proper calcium management. And we have used rotacut in our case, and in our practice we have seen very good results with rota followed by cutting balloon. And in most of the cases, barring a very few, most of the cases we have been able to give good cracks in the calcium and open the vessel with rota ablation followed by cutting balloon inflation. And we have not required IVL a lot in our practice. In these types of diseases, especially in elderly, drug-eluting balloon, combining drug-eluting stents and DEB, it requires metal burden with good results, especially the distal arteries, side branches, and ISR. We have seen very good results, and we have some cases, some patients of ours with a very long-term follow-up, more than 6 months, 1 year follow-up, who are doing very good after rota or after cutting balloon, followed by drug-eluting balloon, they are doing very nice and the coronaries are good. And intravascular imaging is a must in these types of cases because it helps in understanding the actual plaque morphology. It helps in understanding what type of lesion modifying amenities and tools are required so as to open the artery and provide a good result for the long-term benefit of the patient. I welcome your comments and thank you
Well,
very much.
thank you. Thank you, Dr. Wassel, for the presenting this interesting case. And I think first let's switch over to the experts for the opinion on this case. So Dr. Zaman, Dr. Banerjee, your opinion, please.
I saw the case meticulously. So when you struggle in this calcified lesions, you really have limited options, and probably other thing is whether without doing a rota he could have taken a small balloon and try with this. Now the thing is, as you know, it was not crossing, and probably the reason for slow flow and no flow was a repetitive attempt to cross. One option is to take a smaller size bar and to go ahead. Logistic problem is there because then you have to take open another one. You have already invested in the circumflex OM, and probably this patient, Dr. Adil, what was the age, and was this patient of high bleeding risk also?
A 78-year-old patient.
Yeah. So
One
bleeding risk.
just a one point there, taking small bath, there was a problem because we were expecting and there was probably a dissection which was occluding the artery. And then continuing doing rota in a dissected artery, it might have caused more problems than helping.
Agreed.
I mean,
So,
sorry.
so I have nothing more to say. Good result. Patient is doing well.
Yeah.
And thank you.
I was just going to say, like, sometimes also without a dissection, after the rota, there could be slow flow due to, the materials, the calcified materials all being dislodged more distally. But I think in your case there was dissection. And in a dissection, if it's a distal dissection, you are debating whether to put in a drug-eluting balloon or a stent. I'm always worried if the dissection is more, distal dissection, distal to the stent. So I think you put the you put a stent in the more distal LED, right? Ultimately,
No, mid LED only.
immediately, but that
Middle.
was after the dissection.
After the
So,
DEP, probably he put just a spot stenting where the dissection
that's
is.
right. That's right. Yeah,
Now,
I think.
if
No,
it is Antonio Colombo, he may have left it like this.
yes, but that is that's Antonio Colombo would have done. So
Let's
that's
hear
just a
from Dr. Mustafa Jaman.
Yeah,
Dr. Sawan.
thank you. Your end result is very good, but my first question is actually, the patient is 78 years old and a lot of calcium. You're struggling with calcium, both LCX and LED also. So my first question, why you did LCX first? Why not in the LED? Number two,
Yes.
uh, already you when uncrossable, especially in LED, uh, that is a cutting balloon you have used after that is the rota. That means you do not follow the actually in step by step. And another thing in LCX, you may lucky that when you do the professional standing, that is very fortunate that you cross luckily easily. But that may be problem due to calcium in there also. So a lot of question we'll discuss, but first you give the answer this 2 to 3 question. But your end result is very good.
Initial way we did LCX first was we were actually we had planned a provisional stenting technique for LCX, and there was not a lot of calcium in LCX that we had seen on the angiography and the cine. So we were not expecting a lot of problems in LCX, They explained that we will do a balloon dilatation of main LCX and give a stent from crossover LCX to OM and leave it like that. We had not planned a bifurcation stenting in LCX. And we had done because the lesion in the going into the LCX, it was only at ostium. So we had done, before giving stent from LCX to OM, we had already done a balloon dilatation there. And that's why we were able to cross the wire, and then followed by further dilatation. And once we saw that the lesion was recoiling, only then we gave a stent. Otherwise, we had planned at that time also, suppose even if we need to dilate it, we may maximum give a drug-eluting balloon. But the lesion was recoiling, that's why we had to give a stent. Otherwise, we had not previously planned a stent in the LCX.
So your bed preparation is not enough adequate, or you are happy about the bed preparation in LED LCX in both side, both lesion, the vessel
And
preparation.
one more point, sir.
Your bed preparation, that means calcium. You are struggling with calcium, so you are using an LED with rota. But before this, you use cutting or angioscalp or like this, or you direct use the.
Because the problem with going initially with the cutting balloon, the problem was that even a small balloon would not go. We had the lesion was very tight, so the cutting balloon profile is a bit thick profile and a bigger profile than SC or even NC balloon. So if we try to go in with a cutting balloon initially, the balloon may not go at all. The funda of rota is that we want to take our balloon and other gadgets distally. We do rota only if we're not able to take anything at all distally. Then if after rota, once we are able to create a space, then only we are able to take the balloon distally and do dilatation.
So before
after cutting balloon, we can you could see in the IVUS the calcium. Most of the calcium, there were good cracks in most of the places in the calcium, especially the 360-degree and 270 or 180-degree arcs. There were good amounts of cracks, and the vessel opened up.
Okay, and ultimately you deploy one stent or DCB that in the dissected area.
In LED, distally we had given one DCB and a small stent in mid LED.
Mid LED, that means both hybrid.
Yeah.
So already discussed, Antonio Colombo told that, but still now more of debate about the DCB, but especially in calcium. But you are lucky the end result.
We had initially thought of only giving DCB. We didn't think of implanting a stent. But because that dissection had already closed the vessel once, that was the only reason we implanted a small stent there to cover that dissection, focal stent.
So
and distally long disease, we covered with the drug-eluting balloon.
My question also, Dr. Sunip and Dr. Suryamanj also, in this type of dissection, have any role of DCB? Though Antonio Colombo said, I am Antonio Colombo, we can use, but in our practice, but you have you ever all time you practice this type of DCB in this type of dissection, Dr. Subro or Sunip?
Yeah, well, I think if there is a dissection, I would always feel comfortable to put in a stent. I mean, because there would be other things we need as support. So I don't know. I mean, I would be very uneasy to just leave it with DCB. Dr. Banerjee?
No, actually, what is happening over a period of time, the more we are doing the imaging, we have been able to find out a benign dissection and a dissection which can culminate into a vessel closure. Now, one option is to keep a FFR wire, but all the gadgets may not be possible to have in the basket in the same lab. In this case, actually, when the repeat run was done after doing the DCB, we found a intramural hematoma and a dissection which is quite large in the extent of almost 5 millimeter. Now, the thing is, why directly not to stent? We know that it's not the question that the patient may need a CABG in future. That's not the thing. But we at that portion, the more distally you put a stent, and you end up in producing another flap and then another stent. So that full metal jacket is not a good idea, and that's how the DCB was done. Probably in this sort of dissection, not the visual. If the after taking out the wire, if the flow is there, we may leave. Actually, we have done and we have follow up some of cases where we have left it. But on the background of bad calcium and a intramural hematoma and a dye staining, that's very important. Probably the poor man IVAS is the dye staining. So again, the dye staining is a controversial area, that whether dye staining to be chased or not. But probably looking at the all this parameter into orthogonal view, a spot stenting is also a recommendation that you have treated the vessel, you have treated maybe 40 millimeter of vessel, and you have put a 18 millimeter stent in the focal area. That gives a peace of mind and you can sleep well. That's the thing. And probably one thing Dr. Adil has actually tried to get a balloon at the beginning, but it didn't go. And then we have seen multiple times that even if a 1.5 millimeter balloon is not crossing, and then we take multiple gadgets, we increase the time, increase the cost. So that's the reason of upfront rota. That's the purpose.
I think let's proceed. We have more cases. So may I
Sir,
request?
can I add a point? Actually, I have been working for last some time with Dr. Banerjee at Kolkata Heart Lung Center. We are having quite a few patients where we do cutting balloon followed by a DCB, and we are having a very close follow-up of them. And we are doing IVAS in all of those cases, and we find a good satisfactory result, and follow-up is good. And in some patients, we have post angio also, where we are finding that even after some dissections, even which were visible on angiography, they have healed because of the drug diffusion. There is no vessel occlusion or no new lesion formation in those areas. So day by day, we are becoming more and more confident in implanting giving drug-coated balloons in at least in these mild type of dissections, which are not acutely closing the vessel.
Okay, so we
Dr.
can
Adil, my last question: what the medicine actually after the development stand in this case? What should be the actual medical management? Just very short.
The dual antiplatelet, and if it's a very high bleeding risk, then we may decrease the dual antiplatelets for 3 months, and then we may continue with a single antiplatelet.
Okay, thank you.
Otherwise, whatever is the routine.
Good. So yeah, so maybe we can request Dr. Sean Singha. Dr. Singha is a associate professor of Bangabandhu Sheikh Mujib Medical University of Dhaka, and let's yeah, please if you could share your screen.
Sir,
Yeah.
am I visible and audible?
Yes,
Yes.
but your screen isn't here.
Oh, my screen is not here. Okay. Now, am I
I'm seeing
visible?
you. We're watching, but your slide is not. Well, we could not see your slide.
Okay.
Sir,
Okay.
first share the Zoom screen.
So while this is being done, Dr. Vasil, just to continue with what you were saying, so you have done, as you said, with Dr. Banerjee, a number of cases where you have just left it with a DEB. So what's your criteria after IVAS? Like when you think about just, well, this patient could be, we can use DEB or maybe he needs a stent. So are they any different from the usual criteria?
No, not many different visual criteria. We especially look for any big intramural hematomas or large dissections which will close the vessel. Or if there is dye staining on angiography, that may be an indication that this dissection can lead to vessel occlusion. So if it's none of those, and there are mild dissections which are not very much extensive, which are not causing vessel occlusion. There is no dye hanging in there, and there is no significant intramural hematoma, and there is no spiral dissection. We can comfortably implant a drug-eluting balloon and leave the vessel like that.
Yeah, I think before the advent of IVUS, many patients with actually small dissections which were just barely visible, we used to leave them like that. Now I think we have become
Yes.
more sensitive of that.
We are actually seeing now on IVUS, otherwise some of these dissections were previously also left like that only.
Yeah.
But
Sir,
on
am I
accident,
visible now here?
Your slide isn't.
Okay.
No, we couldn't see the slide, please.
Join,
Okay.
you have opened from the browser. So on the bottom line, can you see the
Yes.
share screen option?
Green arrow upside. So just
Yeah,
click
sir.
that button, sir. Share button, and then after that you share your desktop and then open the slide, sir.
Then
Okay,
option of
sir.
screen. Then there will be downward. There will be an option of share screen.
Yes, it's
Yes.
coming.
Yes.
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 Great.
Yes.
Yes, thank
Now
you.
make it
You can
full
just make
screen.
it full, sir.
Go ahead, please.
Okay, sir. Thank you so much. Honorable panelist and dear moderator and distinguished attendees, it's my great privilege and honor to present one of my case here. And I am seeing Dr. Sunip Banerjee, sir, and I am extremely fortunate to work a couple of years ago with him. And I am Dr. Chayan. I am working in BSMU as an assistant professor. In our routine daily cardiac practice, before going to cath lab, to see a very simple lesion, we usually tell that it's a type of lesion, so it requires not so time. But when we used to do this sorts of lesion, we sometimes fall a trouble. And I will just tell a story like that. For that reason, I have selected my title, How a Little Distraction Can Create a Great Threat in Intervention Cardiac Practice. My patient profile is my patient, a 50 years old gentleman who had multiple risk factors for coronary artery disease, like he had hypertension, diabetes, chronic kidney disease, and he is a case of chronic coronary syndrome. And he had a history of non-ST elevated MI managed conservatively 1 year ago. And he had feeling of on and off chest pain despite the optimal medical treatment. And his echo revealed the ejection fraction was good. And for the purpose of to see the coronary tree, coronary angiogram was done. And this is the angio. Here you are seeing that LCX is totally occluded from the mid part, but the optimus marginal branch is quite big. And in the mid LED, there is a significant stenosis. Here, there is a significant stenosis. And in the right coronary artery, there is a significant stenosis in the osteoproximal part. So this is a case of triple vessel coronary artery disease without left main involvement, and the calculated syntax score was 18. So how should we treat this case? Patient age was 50. He wished to do angioplasty by putting the drug-eluting stent. So accordingly, we plan to do angioplasty first into the LED and later into the RCM. We took the EBU 6 pence guide catheter, and the lesion was closed by the taking a run-through floppy wire. And the bed was prepared by taking the peridilated balloon 2 into 15 millimeter, and it was after the balloon preparation, the bed was quite okay. And we took then a drug-eluting stent of 3 into 28 millimeter, and it was deployed in 12 atmospheric pressure. Okay. And after that, we checked, see the stent bush, and we have found that, okay, the result was satisfactory. And after stent deployment, when the stent balloon was pushed, actually it was done without fluoroscope. But at the end, the patient feels unusual chest pain, and all on a rush, the fluoroscopy was given, and we found that there is a mishap has occurred. We found that while tracting the balloon, the EBU guide catheter is just hit the left main, and there was a dissection noted. And we are fortunate that still there was a wire into the distal left main and part of the LED. So in a rush, at the OT, patient was sinking, complaint of chest pain, hemodynamics going to down. We are also feel adrenaline rush. So we pushed the LED wire, and we found a filling defect. Then we also took a wire into the LCX, just secured the LCX also. And after that, we also, in the meantime, we started the inotrop. Noradrenaline was started. And then, just taking a balloon, we dilate the distal part of the LM and proximal part of LED to see the proper for visualization. And after that, we do IVAS run from LED to left main. And during IVAS run, we have found that there was a dissecting flap with interlesional hematoma. And this is the still picture showing there is a hematoma and dissecting flap. So we plan to put a drug-elucidating stent covering the LM to LED. So accordingly, we took 3.5 into 23 millimeter drug-elucidating stent, and we deployed it 10 atmospheric pressure. And the proximal port was done by taking 4.5 into 10 millimeter NC balloon. After that, it was checked. The lesion was properly covered. We are happy to see the flow of the LED. And again, IVAS was run. And later we had found that the good MSA stent was properly apposed. So there was well apposed in covering the lesion. This was the final result. It is quite appreciating the result, though the proximal part of LCX is little bit hazy here, but as we don't do anything here, so for salvage purpose, we keep it as it was. We don't touch it. After the procedure, the patient was settled gradually, normal. And we actually, then we review our case, and we had checked that We know that there's a lots of causes that causes dissection, like guide catheter induced, balloon induced, wire induced. We know that guide catheter induced dissection is commonly occurred in the right coronary artery due to ampullus catheter, and which was very much dangerous. But if the hardware support remains available, and if we keep our patience, actually we can overcome the situation. So sometimes through angiography, meticulous attention, and multiple orthogonal view, we can detect this source of dissection. And by adding some tool like OCT, IVAS, CT, this source of modern instrument can support us. And definitely there is a strategy that if the wire remain within the vessels, we can put the stent, and if wire does not remain in the vessels, then sometimes emergency CABG may require. So my take-home message is that while doing NGO or PCI, we should avoid the advancing the guide too deeply and continuous monitoring its tip. We don't keep the guide engaged too deeply into the LM for too long. And during retraction of the guide, we gently pull and slightly non-selective in approach may be reasonable. And definitely we check the pressure waveform before each injection because it enhances the dissection. And promptly recognition and stent deployment is a very good salvage technique because sometimes it can propagate forward, and if retrogradely, then it can involve the aorta, which may be very much dangerous for everybody. And especially removing the hardware, we should practice fluoroscope guidance. And iatrogenic left main dissections can be managed successfully percutaneously, and preventing the delay in restoring flow compared to conventional open heart surgery. And if we can keep our patience and adequate hardware support, sometimes we need the support of our surgical team, colleague, or expertise, and we should not think any ego, because we have to involve any guys who are expert in this field. সবাইকে সামনে নববর্ষের শুভেচ্ছা. Thank you very much for your patience hearing.
Thank you, Dr. Shingo. I think at the end it was nicely done. And let's have comments from Dr. Banerjee and Dr. Saman.
Yeah, good rescue. 2 points. One is probably, I don't know, Dr. Subro or Dr. Mustafa Jaman, you can tell me that whether this EBU going from transfemoral or transradial behave differently. I don't know. I mean, this is one thing. And the purpose of saying that if I do transradially, that deep sucking is still possible, but probably it's never written anywhere. But from femoral, actually, this probability has been shown to be more exaggerated. This is my thinking. And the for all of us, we have to understand very clearly that the dilution of the balloon with the dye sometimes is not uniform, and it takes time to deflate. And before it get deflated, and if you want to take it out or partially, then all these things happens. That's how. But get rescue, and the great thing you have done is you have not done anything to the circumflex. And what you will not do in future, I hope that you will not give any more dye once you have found that there is a dissection. Thank you.
Thank you.
Thank you
Actually,
so much.
well said, Dr. Shunib. Actually, this is our common problem in cath lab everywhere. And when we disengage the guide catheter, always actually slightly back out a guide catheter during pulling out the wire or balloon or little maneuver, because the deep sitting is a problem. It may cause the dissection, and maybe sometimes in proximal stenting may damage the if we deploy the proximal stent in the LED. And the maintain the coaxial, not only different coaxial alignment is also important. And hold the guide catheter steady, or your control should be in your hand. And another things, you must monitor all time fluoro, under fluoro, anytime. And another important thing that Dr. Shuni Banerjee mentioned, that sometimes the ratio of the actually dilution is not clear, so that there may be cause undeflate and deflate properly. So at that time it may cause a dissection. But here actually the wire is inside the lumen, so it is our lifeline. But the dissection was done by the catheter is 100%, because and another things, when he another wire he actually crossed the through the LCX, that time it is lucky that not cause any false lumen, that is also on the same lumen. But sometimes it may cause in the false lumen also, because there is an intramural hematoma also, because at that time we do not show the actual IVAS. And luckily we can but it may cause any problem also, because if it may cause in that first domain also. But they are also lucky. But when I go to the LCX, it should be the LCX. We can put the stand also LCX also if possible. And another thing, when in hematoma is in late main, so stent should be the at least ostial late main should be covered. Otherwise, it may cause problem. It should be meticulously actually checked. And sometimes I don't know, uh, stain should be little more. I don't know, Dr. Shubhra or Dr. Sunit Banerjee mentioned in that scenario, stain size and caliber should be according to IVAS. Which type of actually learning we can learn from this edition, especially after the IVAS? Size of the stain and the caliber of the stain. Dr. Shubhra?
Yeah, I think that's a good point, because we have seen previously, like if you just put in a stent thinking about this is the length of the dissection, then even after putting the stent, you find there's another dissection comes up. So just distally, proximally. So I think in such a situation, the length of the stent, we must keep a margin for the dissection. And as you have correctly said, if it's involved the left main, is always best is to cover till the ostium, because often if you just land it in the body and cover it and then it extends to the ostium, then that means you have to put another stent and it becomes even more cumbersome. So great. So if there's no more question, I think we have very 5 minutes left, but that we'll give the last speaker his due share. So it's Dr. Jaspal Jadhav. He's an intervention cardiologist from Bardhaman Medical College, and his topic is Tenecteplase saved the night. Okay, good. So
Great.
let's have him, Dr. Jadhav. Yeah.
Good
Uh,
evening, respected seniors. I hope I'm audible.
yes, you're audible and you're slightly visible.
Am I audible?
Yes.
Okay.
Slide is
Okay.
also visible. Go ahead.
So the case, yeah, the case goes like this. So this was like 3 or 4 weeks back, I think. Saturday night, call that 55 years male chest pain, and we were informed that somewhere in Kolkata, I think. But his residence was in Bardhaman only. So the patient had PTCA to RCA with 332 and 328 days, and had stopped the DAPT 4 days before the event. So upon checking, the BP was 90/60 with a pulse rate of around 48, and the patient was having AV dissociation, and he was also having not chronic. I mean, he was having acute chest pain. because the patient had earlier underwent stenting for CSA, and this time the stents there was stent thrombosis, so the presentation was like an ACS, and echo the basal septum inferior wall was hypokinetic, and the EF was 48%. Next slide, please. So this was the CAG, the first shot. Uh, Now the RCA, it was closed from ostium itself. Just after the angio, the patient developed VT, and we cardioverted, and the patient's VT got terminated. Next slide, please. Now this six French that the initial shot was also taken with the initial shot was taken with the Tiger, because we also wanted to check the left system. The left then the second wire. I'm not able to see the slides. Okay. So after and dilated, the previous slide, previous slide.
There's some problem with the connectivity.
Yashpal, your internet connection is unstable, so that's the problem. Anyway, you can show the videos.
Yeah, we can see the videos. Yeah.
Okay.
Yeah, we can see some flow was restored initially after the second dose.
Okay, the next slide, please. The last slide. Okay, if I'm audible, so the take-home message is RC hostile stent thrombosis is always a challenging situation, as it poses difficulty engaging catheters and crossing wires. Aggressive balloon dilatation with the non-compliant balloon must be done. Either 1:1 or 0.5 millimeter higher balloon should be taken. An intracoronary tenecteplase is a cost-effective and readily available option for acute stent thrombosis with huge thrombus burden, avoiding additional stent implantation. The dosing is intracoronary, 1/5 of the total systemic dose is given. A single bolus or two bolus strategy can be used. Rest 4/5 should be given intravenously. Tenecteplase should then be followed by injection heparin 500 international units per hour for 24 hours, followed by LMWH for 2 to 3 days, and the standard DAPT, statins, and adjunctive drugs should be given. Thank you.
Okay, that's an interesting case actually. Of using tenecteplase both intracoronary as well as intravenous in patients with high thrombus burden. So, how long do you normally keep the sheath following the infusion?
Yes.
Yeah. So you have
Sir?
given, yeah.
Yeah.
My
So
question
which
was,
sheet, sir? The radial?
no, I'm saying, yeah, the radial sheath, do you take it straight away? You did it through
No,
radial.
no.
Yeah.
Yeah. Sir, a radial sheath, yes, we take it straight away. But the femoral sheaths, we remove it after stopping the 1080 place,
Yeah.
like at least 6 to 8 hours, or even sometimes more.
Okay. Right. So, but the reason also, like, then when do you do when do you take a reshot? Do you normally take
No,
a
in this case, yeah, in this case, we took the reshot after 3 days. So I think 3 to 5 days, because we completed the intravenous infusion doses, and then there is a system of admission days and all, so we have to do it day wise only. So that's an issue.
Yes.
Dr. Zaman, Dr. Banerjee, your thoughts? Dr. Zaman, you are actually muted.
STMA present lately, Bangladesh, India. So STMA patient may present after 8 years, 6 to 8 hours, or maybe after 12 hours, so maybe late. So at that situation, a tenacity plays actually the behavior actually, which type actually, I mean, our any experience early, late, the tenacity plays behavior, especially in this scenario.
I
This
did not.
is probably a off-level indication, very clearly for stent thrombosis. I think he has done a good job. Ultimately, he got a very good flow and he salvaged the myocardium. So probably it's a AMI sort of situations. But a couple of questions also we could not see the thing very clearly. Why he developed stent thrombosis? Just because of stoppage of dual antiplatelet or malposition of the stent. So if resource allows, Dr. Jadhav, you can take him for a IVAS or OCT, anything. And you were saying that is a ostial stent. So that also the index procedure need to know there are two overlapping stent, both are at 3 millimeter. It seems to be not physiological. So at least the proximal should be 3.5 dilated. So you have any clue to that? What Dr. Mustafa Jamani said, did you have any, I mean, proof of concept or any literature which shows
Uh,
connective place for
yeah,
stent thrombosis is
uh,
there? I
yes,
For
yes.
for this proof, sir, we have searched some articles, because in a case of RCA occlusion, acute MI, it was a very tortuous lesion, like 2 months back. So we just searched, because it was very difficult to wire that segment. Like it was having a 360-degree loop kind of thing. So that time we got some South Indian paper where they have used this strategy, and I think 5 to 6 cases they have reported. They have used a trinity place in these thrombotic situations, and this was our second case at our setup, where we used trinity place in such situation, and in both cases we got good flow in this.
Theoretically, it make actually it's a good. I think it may need more data, but we can do study in this global region.
Yes,
But
yes, sir.
my
Yes, sir.
yes, and another thing, question actually, my we have mixed type of actually observation. The if patient comes early, the treatment is very good in any if type of lesion, but in some patient may present lately. In that scenario, we always do not actually give result good. This is I don't know. Have you any idea or any
Yes, I,
expert panel?
sir. Yes, sir. Sir, maybe in late stages, the thrombus gets more organized, So in those cases, I think a 1080 place may not work well as compared to the very recent ones.
Yeah, because patient could not give the good history always actually.
Yeah.
So,
And
but this,
another thing, what Dr. Sundro initiated is that sheath issue, because you have treated with the thrombolytic, and then I think I have seen people getting multiple blood transfusion because of the local complications. So your patient didn't have any issues like that. It's all
no, sir.
radial you did, or
Yeah,
you
radial side. It was,
treated TQI lead in the transvenous, but anyway, that's. But we have seen very bad hematoma. Is it true, Dr. Shubro?
Yeah, I think even if it's radial, it can cause a large bleed and times can cause compartmental syndrome as well. So because also I was thinking about I haven't actually done this in a patient with stent thrombosis. The only time I've used tenecteplase is patients who have a very high thrombotic burden and coming for primary angioplasty. But late I do not have any experience. But again, like another point is if you have the catheter there, the sheath there, then maybe it would be easier if the patient suddenly starts getting chest pain again, and you can actually take another shot. So, but I don't know. I mean, that's what I thought. But even if since I've given it systematically, I would always be a little worried about taking the sheath out completely.
yes, sir.
But yes, so I think we had a nice discussion today, and thank you
Yes.
all, the
Thank
speakers, for the wonderful case presentation, and Dr. Zaman and Dr. Banerjee for your so kind participation and the good discussion. So, is there anything else that Dr. Banerjee and Dr. Mustafa Zaman would like to mention?
And
No.
thank you. Good discussion, and thank you all of actually with us. And it was very good discussion, and we hope we'll continue this type of discussion. Thank
Yeah,
you.
and I am happy all Dr. Vasi, Dr. Yadav, and Dr.
Join
Thank you.
you.
Chayan, both of them
Yes.
have shown the challenges and ugly face of intervention cardiology, where you lose your adrenaline and you get the challenge, and that's the future, and that's the fact. And so please go on doing good job and keep presenting these things. We
Yeah.
always learn from each other.
All
Thank you.
cases were very nice, nicely done.
Thank
Yes.
you very much.
Thank you.
Thank you.
Okay.
Thank you, sir. Thank you
So,
so
Sir,
much.
good night.
Mr.
Good night, sir.
Otonu Banerjee now.
Otonu Babu. Yes.
No, sir. Thank you, sir. Thank you very much, sir. Nothing from our side.
Thank you very
So it's
much,
very
sir.
nice.
Thank you.
Thank you, sir.
Bye bye.